Hi guys, welcome to yet another class in our labor room series. So today we are going to talk about instrumental delivery. Just quickly let me know if I am audible and visible and then we can be on our way. Okay, so today's class is going to be on instrumental delivery. Now, this is a very important topic from the point of view of your final year exams in your Viva. You can be asked about this. This is also very important from the point of view of your entrance exams. There are a lot of questions on it, right? So, in almost every alternate session, you may find a question on instrumental delivery. Good evening, Dr. Spam. I hope that's not what you're going to do today. So, okay, good evening, Dr. Ashutosh. All right. So today's class is very important, like I said. So we are going to talk about how we can use certain instruments to facilitate our delivery. So just to give you an example, how many of you who are here, you have watched the movie called Three Idiots? How many have watched the movie Three Idiots? So Three Idiots, mein, there was a scene, one of the most pivotal scenes in the movie when Viru Sahasrabuddhe actually starts liking Amir Khan for the reason why he is able to revive his grandchild, right? So yeah, so do you guys remember what happened there? Just the scene preceding that scene when he says all is well and the baby comes back to life. So there is the scene of the delivery. So we see that Kareena Kapoor's sister, she is exhausted and she's trying to push, but she's not able to push, and people are really trying to, egg her on, push, but she's not able to do it. And finally, what does Amir Khan do? Amir Khan takes a vacuum, and he pulls the baby out. Right. So that would be an example of an instrumental delivery. So basically, when we talk about instrumental delivery in obstetrics, we have two instruments at our disposal, and we will be talking about both of these one by one. So we will talk about the instrument that Ranchod Das used in the next class. Today we are going to talk about another instrument called the forceps. Right. So we are going to talk about number one, forceps, and the second thing that we have is called vacuum. So we don't use a vacuum cleaner, we use a vacuum. The other name for this is ventouse. So ventouse or vacuum, right? And forceps. So today what we are going to talk about is mainly about the forceps. A little bit in general, we'll talk about instrumental deliveries, and then we will talk about forceps, and in the next class what are the advantages and disadvantages of each. So this is going to be the overview of the next two classes, right? So what is going to happen is, number one, the first question that we ask is, what is the need for instrumental delivery? Why at all instrumental delivery? So it has been seen that, a lot of times what happens during labor is that towards the end the mother really gets exhausted. So she's been in labor for, a good number of hours, and she's exhausted, and you've been trying to hydrate her or tell her to eat something, but she's not been able to do it because of the pain, and she generally gets exhausted. The other thing that has been seen is that the cesarean section rates are very high. And a lot of times what was happening was that just when the baby was about to deliver, which is the mother was 10 centimeters dilated, the baby was almost out, the baby would go into distress, or the mother would stop pushing because she was exhausted. And because she was exhausted, the baby would then, sort of go into a distress. And unfortunately, at a very tempting stage of per vaginal examination, when the baby is just going to come into your hands, you would have to do a cesarean section. So instrumental delivery is basically just a way to expedite normal delivery when a mother is not able to do it herself. So we are just giving some sort of an aid to the mother कि आप vaginally delivery करा लो in order to prevent a cesarean section, right? So we all know, and we've talked about this multiple times, how vaginal delivery has a lot less morbidity than a cesarean section in most of your low risk cases. So instrumental delivery helps us achieve just that. Now that I have said it, what I really want you to understand is, it is important in decreasing the cesarean section rates, The thing that I want you to really understand over here is ultimately when we are using an instrument, how are we taking out the baby? We are taking out the baby through the abdomen. Where are we taking it out through? We are taking out the baby vaginally. We are taking out the baby vaginally. So vaginally ही हम निकाल रहे हैं. वो vaginal delivery the mother was not able to do, or we were not able to conduct due to whatever reason, or the vaginal delivery was going very slowly and we needed to speed it up, maybe because the baby was in distress, hum itna wait nahi kar sakte. In that case we use an instrument, right? So what I want you to note over here is, in order to do an instrumental delivery, it is important that vaginal delivery is possible. Which means what? Which means that you cannot have a case where the baby is too big for the pelvis is too small for the baby, and you are trying to take out the baby vaginally. Ultimately, remember, the baby is coming out vaginally. The dimensions, the head diameters of the baby are not changing. They are the same. तो vaginal के लिए अगर उसको निकलने के लिए wide pelvis चाहिए था, instrument के लिए भी it needs a wide pelvis. So remember, there has to be, in order to do an instrumental delivery, there has to be no contraindication to vaginal delivery, which means a lot of kids say this, ma'am, we can use it in case of CPD. So instrumental delivery can't be done in case the pelvis is inadequate for the fetus. So this is one point that should be absolutely clear to all of you guys before we proceed, right? I hope this is clear, guys. I hope this is clear. Then we can move on. All right. तो अब हम instrument जो लगाते हैं, when we apply an instrument, remember, and I will tell you what exactly we are doing in an instrument. There is a lot of pulling, there is a lot of tugging in the instrument, and there are huge instruments that are going in. For example, this is what a pair of forceps looks like. This is what forceps looks like. So this is something that we are inserting inside the vagina of the mother, and we are grabbing the baby and we are pulling it out. Right. So remember, this is a very, very traumatic process. This is a traumatic process. This is not a, it is not a normal delivery. So when we talk about normal delivery, we talk about, what WHO says about normal delivery. Remember, normal delivery is going to be a delivery that is happening at term, which means after 37 weeks, right? And it is a singleton cephalic fetus, and you are delivering the baby with minimal aids. Now, what do I mean by minimal aids? Minimal aids means I am just giving an episiotomy. That is it. So these instruments, they are not minimal aids. So when I take out a baby using this is not a normal vaginal delivery. This is an instrumental delivery. This is an instrumental delivery or an operative vaginal delivery, right? So what happens is, because this operative vaginal delivery, it can be traumatic for both the mother and the fetus. That is why we don't do it in everybody. Right, we just don't do it because, oh, she's been full for such a long time and बहुत time हो गया, मेरी shift खत्म हो रही है, तो let me pull out the baby. That is not how vaginal delivery, that is not an indication, that is not how we use the instruments. There are very, very clear cut indications of using instruments, and we will talk about them right now. So when exactly do we use an instrument? एक तो instrument use करने के लिए, remember, the mother has to be fully dilated and fully effaced, which means what? The head is not encumbered. The head does not have any maternal cervix soft tissue around it, right? Because if I apply the forceps to the baby and there is soft tissue around it and I pull, the cervix is also going to tear off. Right. So I cannot do it unless and until the mother is fully dilated and fully effaced. Right. So mother is fully dilated and fully effaced. Right. Now, what is happening is that आपको लग रहा है vaginal delivery हो जाएगी, right? And you are rooting for a vaginal delivery. But unfortunately, what happens is that the fetus starts having distress, right? Now, the fetus is having distress. Usually, whenever the fetus has distress, we have to deliver the baby quickly. We have to deliver the baby quickly. We cannot wait कि अच्छा मम्मी को, we cannot let nature take its course, right? Unless and until the baby is just going to pop out. So unless and until I feel कि vaginal delivery बस होने ही वाली है in a couple of minutes, then I need to intervene. Now, usually, whenever there is fetal distress, we will quickly take out the baby through a cesarean section. However, agar the mother is fully dilated, fully phased, and the baby has descended quite a bit, and I know कि vaginally nikal sakta hai, then I am a little tempted that why should I do a cesarean for her? Let me quickly take it out using an instrument. So one of the indications of using an instrument is what? Obviously, all your prerequisites have to be fulfilled. One of the reasons why you would use an instrument is for fetal distress, right? The second reason why you might use an instrument is for the mother. For the mother, how? For example, like Mona in Three Idiots. Like if the mother gets exhausted and she's not able to push anymore, it is fully dilated, fully phased, right? She's not able to push anymore. You don't want to do a cesarean. So in that case, we might use an instrument to take out the baby, right? Or if the mother has been in the second stage for very, very long, and the duration of second stage is what? 2 hours in primary, and in multigravida 1 hour. So this is the amount of time that we are allowed in the second stage. If she has epidural, then we can allow 3 hours in a primigravida and 2 hours in a multigravida. So for example, this mother has been fully dilated, fully phased for, she is a multigravida and she has been in this state for the last 1.5 hours. We know, so if the prerequisites of instrumental delivery are fulfilled, then we can use an instrument and we can avoid a cesarean section, right? So maternal distress, I have told you, this is quite simple to understand. Fetal distress, quite simple to understand. Prolonged second stage also. Now remember, when we talked about breech, I talked about a very special forceps for the after coming head of breech, which was called the Piper's forceps. Piper's forceps, this is for the after coming head of breech. Now there is another indication that you need to understand, that is prophylactic application. So I told you what is हम ऐसे नहीं करते कि ओहो बहुत टाइम लग रहा है मम्मी को तो खींच के निकाल देते हैं इंस्ट्रूमेंट से. That is not prophylactic application. Prophylactic application has very, very specific indications. So this is called prophylactic application, is also called cut short the second stage of labor, which means what? Second stage of labor का अभी time पूरा नहीं हुआ है. It has not been a full 2 hours for the primigravida or a full 1 hour for the multigravida, but we are cutting short the second stage. But you will say, ma'am, you just said कि ऐसा नहीं होता है कि आप randomly निकाल दो just because you know she's taking a lot of time. So like I said, ये cut short second stage के भी there are very, very specific indications. What is that? What is that? Problems like if the mother has a heart disease, problems like if the mother has severe anemia, problems like if she has severe preeclampsia. Why is that? Why is that? Can anybody tell me? So remember, what is happening during labor is, during labor, the mother is in pain. The mother is in pain. So the pulse rate increases. She has tachycardia. What is cardiac output? Cardiac output is pulse rate multiplied by your stroke volume. So what is happening to the cardiac output? The cardiac output, it is increasing due to the increase in pulse rate. In addition, what is happening? Stroke volume is also increasing. Why? Because every time there is a contraction, all the blood in the sinusoids in the uterus, they are getting pumped back to the maternal circulation, right? So what is happening in this case is your cardiac output is increasing a lot in the second stage of labor, right? And this increase in cardiac output can lead to what? It can lead to an overload in the system. It can lead to pulmonary edema. It can lead to congestive heart failure, right? Now ये हर इंसान में नहीं होता. This doesn't happen in everybody. It happens in places where the mother may already be predisposed to this. For example, if the mother has severe anemia, she already has a hyperdynamic circulation. The heart is beating very fast to try to keep things going. If she has a cardiac disease, she's already compromised. She's already at risk of a congestive heart failure. In case of severe preeclampsia, again, she's already at high risk of pulmonary edema. So in these cases, we do not want कि मम्मी बहुत ज़्यादा चीखे चिल्लाए अपना tachycardia करे. So in that case, what we do is we cut short the second stage of labor by applying instruments. So I hope the indications of instrumental deliveries are clear. So this is a list that you need to know, and this is a list that can be asked to you in your exam. I hope this is clear, guys. Okay. So moving on, this is what the forceps looks like. I've already told you this is what the forceps looks like, right? And we will talk about when do we apply the forceps? When do we apply the forceps, right? So when we talk about when do we apply the forceps, there have to be certain prerequisites, certain criteria that need to be fulfilled. So thankfully for us, the criteria for applying, for being able to apply forceps is given by the mnemonic, which is forceps itself. So F stands for the mother should be fully dilated and fully phased. That I already told you. There should be no soft tissue that is surrounding the fetal head, right? And apart from that, apart from that, the membranes should be ruptured. There should be nothing surrounding the fetal head. So there should be no bag of membranes also. And rotation should be complete. Remember when we talked about normal labor, we talked about how there is a step. There is engagement, flexion, and descent, and then there is internal rotation, right? So this rotation has to be complete. If it is not complete, it can be within 45-degree, but it should not be more than equal to 45-degree, right? So rotation should be complete. The baby should be cephalic, preferably in the vertex position, right? You should have given an episiotomy. You should have given an episiotomy, and your bladder should be empty. The pelvis should be adequate, which means there should be no cephalopelvic disproportion, and the station should be +2 or lower. So what do I mean by station should be +2 or lower? So this level, at the level of the ischial spines, is what is considered zero station, and we've talked about this. So 2 centimeters below that is +2. 2 centimeters above that is -2. So +2 or lower means the baby should have descended at least 2 centimeters below the ischial spine. So the leading point of the fetal head should be at least 2 centimeters below the ischial spine. Right. So these are the criteria. These are the criteria for applying forceps. Now, whenever you are doing an instrumental delivery, you have to go in knowing, and you have to be very, very open to the possibility that this delivery might fail. And you also need to realize this is a traumatic procedure, not just for the mother, it can also be traumatic for the baby. It could even be a baby who is in distress. हो सकता है इसी reason से आप instrument लगा रहे हो. So you need to have a neonatologist, right? And because this is traumatic, you need to have गुड मैटरनल एनाल्जीजिया. अच्छे से एनाल्जीजिया देना है, चाहे आप उसको दो प्यूडेंडल ब्लॉक, इफ शी हैज एपिड्यूरल दैट आल्सो वर्क्स. कुछ और नहीं तो कम से कम लोकल एनेस्थीसिया शुड बी गिवन, राइट? सो you need to have adequate maternal analgesia. You need to have a neonatologist, right? And importantly, you need to have a backup plan if the procedure fails. And what is that backup plan? Cesarean section. Most importantly, whenever we are applying an instrument, and this is more true in case of forceps than in the case of vacuum, jo laga raha hai, the person who is applying the forceps should be very, very experienced. So you need to have an experienced operator. So instrumental delivery, just like breech delivery, is an art. If you are confident, only then you should go along with it. I am good, Dr. Ram. All right. So these are the facilities that must be available, and these are the criteria that need to be fulfilled before you go for a forceps delivery. So let's talk about the parts of a forceps. Let's talk about the parts of the forceps. Right. So this is the handle. This is the handle. This is where I put my finger and I pull. So this is the finger guard. Right. Then you have two blades. So this can be dismantled like this. This can be dismantled like this, right? And they fit together over here, right? So where they fit together, this place, this is called the lock. Look at the picture below. This is called the lock, right? And these are the shanks. These are the two blades. These are the two blades, right? इसके अंदर एक curve है, you can see, and you can see there's a curve outside. There's a curve outside, right? So how it is applied, finally, final application looks something like this, right? So what you can see is that the outer part, what you can see is, So I want you to look at this. I want you to look at this. So what you can see is that the outer part of the blade, the outer part, this curve is opposed to the pelvis of the mother, whereas the inner part of the blade is actually wrapping around the head of the baby, right? So this inner part is called the cephalic curve, and this outer part is called the pelvic curve. This outer part is called the pelvic curve. Right. Now, if I look at these blades, there is a left blade and there is a right blade, which is what? How do you identify it? So you can see, so what you can see over here is that the part that is going to face upwards, that has a concave curve. That has a concave curve, right? Obviously, this convexity is going to be outside, right? So this concave curve is going to be upwards. And when it is locked, it looks like this, right? Now, the part that is going to go towards the maternal left pelvis will be called the left blade. And the part that will be going towards the maternal right pelvis will be the right blade. Right. So this will be going towards the maternal left pelvis. So this is the left blade. This will be going towards the maternal right hemipelvis. So this is the right blade. And this is a question that they ask you. So you should know identification of blade, whether it is a right blade or whether it is a left blade. Now, this is important. This is important because when we talk about application of forceps, you will understand why it is important to identify which blade is what, right? So now we have different types of forceps. There are actually many different types of forceps. So there are classic forceps, there are forceps. So I told you the rotation needs to be complete, but earlier we used to use some rotational forceps also, and you just need to know the name. The name is Keelan forceps. So this is no longer used in India, but still in the United Kingdom, they're still using it. Right. And there are certain specialized forceps. One is Piper's forceps that I already told you is used in the aftercoming head of breech. And then there is the Barton's forceps, which was used earlier for deep transverse arrest. So this is not used anymore, not used anymore. Then there are the classic forceps, which can be long or short curved. So the classic forceps are the ones that we are using most regularly. And of this, we usually use this. And we have two in this. So we have one that is the outlet forceps. And then we have the low cavity forceps. So you should know the name of the outlet forceps. The one that is most commonly used is called the Wrigley's forceps. Literally, the only difference between them is the length. The only difference between them is the length. So the one that I showed you is the Wrigley's outlet forceps. The only difference between them is the length. So the long one is low cavity, the short one is your Wrigley's, right? So when we talk about your outlet versus low, what is the difference between the two? One difference is the length, right? But agar wo aapko, for us who've been doing gynae for a while, agar mujhe koi forceps pakda de, if somebody gives me the forceps, then I will be able to tell what is the difference between the two. I will be able to identify, right? But for people who are doing their MBBS, it might be difficult. So usually they will tell you this is a Wrigley's forceps or this is a low cavity forceps, right? Now the question that they ask you, unless they place them side by side, you'll not be able to tell. So the question that they ask you is, why did we make two different sorts of forceps? Is there a difference in function? Is there a difference in function between the two? Yes. And the difference in function is given in the name, right? So outlet forceps, remember, is applied at the outlet, right? Which means what? The head is at the perineum. Bas nikalne hi wala hai. The head is at the perineum, right? So this will correspond to somewhere near your +4 or +5 station, right? So the head is at the perineum. Obviously the rotation needs to be complete. Head agar perineum pe hai, to it is far below your +2, right? This is when you apply the outlet, right? And when I talk about the low cavity forceps, low cavity hum kab karte hain? Low cavity, obviously +2 or lower pe hi we are applying this, right? So it is applied in the lower part of the cavity, but not at the outlet, between +2 to outlet. Between +2 to outlet, basically +2 +3 पे, we are applying low cavity forceps. Right. So this is about the different kinds of forceps that you might be given. Now, this is important because why? Sometimes they give you questions. Sometimes they give you questions or they can give you MCQs where the answer you will be able to tell is the forceps delivery. If the answer is forceps delivery, but sometimes they will act very smart and they will give you two options, and the two options will be either outlet or low cavity. So the only way that you will be able to tell which one is to be used will depend on the station of the head. Is this clear, guys? Is this clear? Now, moving on. Pipers, I have already told you. Pipers, I have already told you. So this is Bartons. This is Bartons. This is used for deep transverse arrest. Pipers, I have already told you, is used for the aftercoming head of breech. So nobody's going to ask you about this, right? Except they might just ask you which forceps is used for the aftercoming head of breech. A recent INI question was they gave you a picture where the baby was delivering breech, right? And only the head was left, and then they were using a forceps and they asked you what forceps is this? So that was Piper's forceps, right? Okay. Now, moving on. So before we do an instrumental delivery, there are certain preliminaries. So there has to be a documentation which should include your informed consent. Very recently, there was a case in the UK where a woman sued a doctor because she did not obtain proper written consent before doing an instrumental delivery, right? So informed consent is very, very important, right? And you need to talk about if there are any comorbidities. Right, you need to talk about the indication why you are applying it, right? Because it is a traumatic process. In case things go south, things don't work out very well, then your documentation should be proper that this was the indication, this is a valid indication, and this is why I applied the instrument, right? There has to be anesthesia. So epidural, if she already has, good. If she does not, then at least a pudendal block or local anesthesia. Bladder emptying is very important, right? Because it helps the head to descend down, right? And that is very important. And internal examination to document whether criteria are met, right? So you might be right in thinking कि हाँ maternal exhaustion हो रहा है, fetal distress हो रहा है. So this is a valid indication for taking out the baby through instrument, and you would probably be right in taking it out if the internal examination criteria are met, right? But if your internal examination criteria are not met, for example, the mother is exhausted, the baby is having fetal distress, you need to deliver the baby fast, but your os is not completely open, it is only, for example, 5 centimeters open, usme you try to apply the forceps. Yeah, your rotation is not complete, usme you try to apply the forceps, you are going to have catastrophic consequences. Babies have been known to lose an eye because the forceps have been applied in the wrong place and all of that. So internal examination to document whether the criteria for forceps delivery are met or not. And of course, episiotomy, again, there are no guidelines which say a routine episiotomy should be given, but episiotomy is preferred because this is a traumatic process, right? And it can lead to anal sphincter tears, right? So this is about your preliminaries. Now, how do we apply the forceps? So when we apply the forceps, ideally the correct application of the forceps will have your forceps applied in the occipitomental diameter. Occipitomental diameter. Right. So this is the mentum or chin and this is the occiput. So the occipitomental diameter is the right application of the forceps. Right. So occipitomental diameter I have already told you, and ideally your forceps should lie over the parietal bones and the tips of the blade should lie over the cheekbones. Right. So this is about the application of forceps. Now let's talk about how do we apply the forceps, and this is something that can be asked to you in your viva in your final year. So the first step, obviously, before all of this, you have to have your consent, your bladder should be empty. All of those things I have already told you, bladder empty, you should have done your internal examination, criteria met, all of these things should be there. Indication should be checked. But after that, when we actually apply the forceps, then what are the things that we need to do? First thing that we need to do is check whether the two plates of the forceps actually belong together. And how do we check that? How do we check that? By locking them together. By locking them together. So this lock is coming together. This lock is coming together, which means these forceps belong to the same pair. And this I'm doing outside of the mother's body. I'm not experimenting inside the mother's body. ये मैंने बाहर ही लगा के देखा है. And this is called what? This is called phantom application. Phantom application. So your examiner will cut 1 mark if you do not mention phantom application before you start applying the forceps, right? The next thing that we do is we apply the left blade, apply left blade of forceps. So look at how we are applying the left blade of the forceps, right? It is going to come over the parietal bone of the baby, which means what? ये side में आएगा, but हम नीचे से जा रहे हैं. We are using our right hand to guide the left blade of the forceps through the foreshed. So this is the left blade of the forceps that I have put first. Then I hand it to the examiner. So hand it to my assistant. So this is the left blade. This is the left blade. After the left blade has been introduced, then we introduce the right blade. Introduce the right blade. Right. And once the left and right blade have been introduced, once they have been introduced, then we lock the blades. So when we lock the blades, what happens is that these two handles, they should come together. And that means your forceps has been applied properly, right? So let's just look at it over here. So the baby is over here. So first what we are doing is we are applying the left blade of the forceps, right? ये नीचे से हम जा रहे हैं. Then I am turning it 90 degree, right? And I am handing it to my assistant who I don't have over here. Then what we are doing is we are taking the right blade and we are applying it over here. Same way we are applying it over here, and then we are locking it. Right. So what you see over here is, because I don't have an assistant and I'm not able to show it to you properly, it is not locking, but these should lock. Let me just lock it for a second. Yeah. So now this is locked. Right. So you can see the handles are together. This is locked. The baby's occipitomental diameter is over here. And now I can pull the baby out. Right. So locking of the blade confirms that the forceps has been applied properly. Right. So these handles should come together. Now, after it has been correctly applied, only then will we pull. Right. And we will pull with the wrists, not with the elbows. Right. And the pull should be made when there is a contraction. The mother should not be relaxed at that time. Only when she is having a contraction should you pull, right? And when again crowning happens, that is when you give the episiotomy. And once the head of the baby is out, you remove the right blade first, followed by the left blade. Right. Now let us talk about pull hum kar rahe hain. How should I pull? Should I pull like this? Should I pull like this? Should I pull like this? How should I pull? So direction of pull is important, right? And it is quite logical if you look at it. So remember, when we talked about the maternal pelvis, we talked about this curve of the birth canal. And this curve, does anybody remember the name? What is the name of this curve? This is called the curve of Caris. This is the curve of Caris. So basically what we are doing is we are going to follow the natural path of the birth canal in our pull, right? So if the baby is just at the outlet, which means what? We are using the outlet forceps. So my direction of pull is going to be this side, right? But remember, the baby delivers its head by extension. So it is going to be straight and upward. So in case of outlet forceps, I hope this is clear, guys. In case of outlet forceps, it is going to be straight or forward, followed by upwards. But if we are using a low cavity forceps, which means the head is higher up, the head is over here. So in this case, we will have to pull it down when it comes to the level of the outlet, and then we will pull it straight and upward. Right, so we are just following the curve of Caris. So in this case, it will be downward and backward, followed by straight, followed by upward. I hope this is clear, guys. I hope this is clear. Right. And now one thing that is very, very important, more important than the person, who is applying the forceps, what is very important is the person who is giving perineal support. So perineal support is very important. Give a liberal episiotomy because, there can be a lot of tearing in the perineum. So give a good perineal support. And usually, when we are doing a normal delivery, एक ही इंसान डिलीवरी लेता है, दूसरे हाथ से एक हाथ से फ्लेक्स करता है हेड, दूसरे हाथ से पेरिनियल सपोर्ट देता है. When you are doing a forceps delivery, please, no shame in asking for an assistant to give perineal support. In fact, you will be much more sad, you will be in much more soup if you do not give a good perineal support because you try to do everything on your own, and what you find is the mother has an anal sphincter tear, right? So this is about the application of forceps. Now let's talk about the complications. So when we talk about the complications, there can be maternal and fetal complications. So like I told you, and I will tell you this, forceps is more traumatic for the mother, more traumatic for the mother. Right. So there can be injury to the cervix, there can be injury to the perineum, to the vagina, there can be rupture of uterus, there can be obstetric anal sphincter injuries. We will talk about this when we talk about third stage complications. But basically, what is happening is that this is your vagina, this is your anus, and because of this trauma, this has gone all the way down to the anus, and now your vagina and anus are one single opening, and this woman is now going to have what? Fecal incontinence. There can be PPH, there can be infection, there can be hematoma. So these are all the complications that can happen. In fetus, relatively the complications are more in vacuum, less in forceps, but still you can have skull fracture, you can have marks on the face, right? Bruising and laceration. These are actually the most common, right? There can be facial palsy or brachial palsy also. Now, coming to the last two topics, which is trial of forceps, trial of forceps. Trial of forceps का मतलब क्या है कि I am sitting in a place where I have facilities for a cesarean section, but I do feel like कि मैं instrument लगाऊंगी तो हो सकता है कि वो जल्दी बाहर निकल जाए. But in my head, I somewhere have this that this might fail, right? So this is an attempt at forceps application with the knowledge that it may fail, right? And if it fails, I will immediately have to do a cesarean section. So what am I doing? I am taking this patient inside the operating room, right? And have told the anesthetist I am fully prepared कि अगर बच्चा नीचे नहीं आया, then I will have to do a cesarean section. And finally, when do you say actually बच्चा नीचे नहीं आया, the forceps has failed, you are not able to deliver the baby, and there have been 3 pulls, 3 times you have pulled and you have not been able to deliver the baby. That means this is a failed forceps. Abandon all further attempts and go towards a cesarean section. So that is it for today's class. So this was it about forceps. So I hope you understood. If there are any doubts, I will take them now. Is this clear, guys? All right. So I will see you next week with the next class, which will be instruments part 2. And we will be talking about the vacuum or ventouse cup. And that will be the end of instrumental delivery and all the delivery mechanisms. And from there, after the next class, we are going to go forward with some theoretical knowledge on what does the WHO say about the labor care guide, about all of those things. We are going to talk about those, right? So that is it for today's class, and I will see you next week. Bye bye.